In this video, we're going to talk about epidural injections. It's something that I do quite a bit of. It's very much an important part of chronic pain management as it pertains to the spine. Epidural, what does that mean? It means top of the dura. So if you look at the basic anatomy of the spinal column inside the spinal canal, what you'll find is a thecal sac, inside of which is spinal fluid and also spinal nerves as they come down the spine. The thecal sac is made of the dura. There's actually three layers, which you don't need to be concerned about, but it's made of dura, and on top of the dura is the epidural space, and that's where the needle is lodged. So it's inside the spinal canal, but it's on top of the dura or around the thecal sac. It mostly consists of fatty tissue and is quite voluminous. Like in the lumbar spine, we can inject 50, 60 cc's of fluid and we wouldn't have any problems. And it's contiguous all the way up and down the spine. And there are different pockets in the epidural space with recesses here and there, but we don't need to be concerned about that. And the epidural space is contiguous with the foramen and off to the side, and the interlaminar space between the laminas, and I'll explain that. That's part of the roof of the spine or the bony spinal canal. But between the lamina, or between each level of the vertebral body and the posterior elements, there is a little space that you can insert the needle to achieve epidural space position of the needle. And so you can have interlaminar epidural, or what we call transforaminal epidural injection. Okay, I'll explain that later. This is what it looks like. We use fluoroscopic guidance, and it is a standard of care. Probably 10 to 15 years ago, a lot of these were done blind in the office, but we don't do that anymore. And so let's go over the anatomy really quick. This is the x-ray view, what we call anterior posterior view. These are all anterior posterior views. This is the lumbar spine. You can see the hip or the pelvic bone on the sides. This is the L5 vertebral body and L4. And when you look at the handles off to the side, you got the transverse process. You see that? Okay. And it's connected to the pedicle, and that's the darker part of the spine on the vertebral body. So those are pedicles right there. And then these teardrop shaped looking things are spinous process. They're jutting out straight towards us. Let's look at this picture. And when you look at x-rays, one of the signs that you look for are what we call owl's wink sign. We don't see that much in my practice, but when cancer invades the spine, they typically attack the pedicles, or they can, and the pedicles lose their bony element, and the circle, which looks like an owl's eye, disappears or looks different. Okay, but this is a pedicle transverse process, the spinous process. But look at this entire kind of like square section of the bone. This is what you call the lamina. Okay, this is the roof of the spinal canal. Okay, the vertebral body, which is in front, is the square-looking, bigger structure, the vertebral bone, or vertebral body. This is the interlaminar space. You see that little opening right there? That's the space where we put the needle, and you see this needle sticking in there. This is the interlaminar approach. Okay, interlaminar approach is simply a shotgun approach. When you inject uh, medication into this space, everything goes up and down and off to the sides, and they kind of fill up most of the space. But when you go through the interlaminar space, the needle is actually lodged on back of the dura. If you look at it from, I don't have a side view picture, but if you look at it from the side, if you go through the back, obviously you're going to be on the back side of the spine because you're not going to go through the thecal sac, right? And so the medication is going to end up on the back side of the spinal canal. But when you put the needle on the side, okay, this is where the spinal canal is, and then nerves exit through underneath the pedicle, right, which is the pedicle at each level, okay? And so there's a hole here, which is called a foramen. We can put a needle right underneath the pedicle right here and access the spinal canal from the side. And if you do it from the side, the medication flows anterior to the thecal sac. And so the arguments have been made that transforaminal approach is superior. And studies haven't really supported that, but logically it makes sense, and it's more targeted approach. You can target the specific nerve that's coming down. And since we're treating the nerve, we can put the needle right next to the nerve and have medication flow up along the course of the nerve. Particularly when you have stenosis or narrowing of the canal, we like to do targeted approach because narrow of the canal means that there's a narrowing of the canal, and if it's narrowed, it's a tight space, and if you just did an interlaminar space, medication doesn't quite flow into the tight space. They typically flow out to the areas that are that have more space. So arguably, it's difficult to get medication right at the target. So when we have stenosis and a specific pain down the leg, then we like to do a transforaminal approach. Typically, I do mostly transforaminal approach. Okay, so you got interlaminar approach, you have transforaminal approach, and we'll talk about that a little more later. So transfemoral approach is where we put a needle right under the pedicle. Here is you'll see this one. If you can guess which nerve is coming out underneath the L5 vertebral body, it should be L5 nerve, right? So this will be L5-S1 transforaminal epidural steroid injection, right? Because the holes are named and numbered by the level above and level below. So this is S1, this is L5, so this hole is named L5-S1, and so this is transforaminal approach, and therefore it's called L5-S1 transforaminal epidural steroid injection. Another name for this is selective nerve root injection. We don't use that as much, and there's a lot of confusion about different terminologies. Some people used to call it nerve blocks, but the nerve blocks are confused with the dorsal medial nerve injections that we do, which sometimes people call nerve blocks as well. So I don't like using that. So selective nerve root block would be appropriate. And there's really not much difference between selective nerve root injection or block versus transforaminal epidural steroid injection, although some arguments can be made depending on the volume that you use. But look at the cervical spine. This is the neck, and the head is up here, and then this is the thoracic spine, and this is the first rib that's coming out, so we know this is T1, right? So this would be T1, T2 interlaminar epidural steroid injection, and you can see that this guy didn't quite hit the sweet spot, which the needle should be right in the middle, but this is fine. I think I got this off the internet. So you put a needle right there, and you inject the medication. I think there's some line attached to this needle, and then I think this is a marker. They may have put this. Now some guys use a marker. I don't, but anyways, this is an interlaminar cervical epidural steroid injection. Now, if you look at these two pictures, there's no contrast injected. We inject a little bit of contrast in there just to make sure that we're getting the right spot. And this one, you can see the darkening right underneath the pedicle, which means that you've got the needle in the right spot. And then the contrast is found in the epidural space. It's flowing up some, and then it's also flowing down to this level. These are the recesses, the lateral recesses. That medications typically flow. Other times you'll see a straight line that goes up like this. It goes right up against the epidural space, and it really shows a nice outline of the nerve root. This is a cervical epidural steroid injection. You can see that there's a large transverse process with rib cage coming out. So this has got a T1. This is C7. They label this at C6. If you have a hard time counting these vertebral bodies, you don't have to count them, but you can look at the spinous process here and just count those. It's C5, C6, and C5 right here. And you don't see it very well, but needle is lodged between C5 and C6. Medication injected. This line is actually the nerve that's coming out, and it's going into the epidural space off to the side. Okay? So, we talked about epidural steroid injection, that we have the transfemoral approach, interlaminar, there's caudal, but you don't need to know that, and I explained the selective nerve root injection, or SNRB. Caudal is, I'll explain that. Okay, so epidural steroid injections are typically given for two different conditions. One is herniated disc or protruding disc. The other one's spinal stenosis, and you can have a variety of different spinal stenosis. You can have central stenosis where it's narrowed in the middle. You can have foraminal stenosis where the hole is narrowed, and you can have a herniated disc that irritates the nerve that's either coming out of the hole or that's descending through the lateral recess or inside the spinal canal, what we call the exit lane. As the nerves get ready to exit, they go over and hug the pedicle inside the canal before they exit. That area can be an area where the herniated disc crowds out. Now, herniated disc does not necessarily have to compress or impinge the nerve root. Herniated disc can cause chemical irritation of the nerve roots, and these nerve roots are quite sensitive for obvious reasons, and they can become inflamed and irritated. So there's a lot of studies that show that when you have a herniated disc and you biopsy the actual nerve root, there's a lot of inflammation markers that have been elevated multiple times. And there's actually immunologic response against the herniated disc material that they've been able to document inside the spinal canal. So when the disc herniates, it causes a lot of havoc, and namely inflammation. And this is fairly well documented. And so this is why we put a needle next to the nerve or through the interlaminar space to kind of flood the entire area with some corticosteroid to decrease the inflammation. So this would be transfemoral approach. And oh, by the way, this is the caudal approach. There's a little hole in the coccyx where you can introduce needle. But the problem is that you have herniated discs that are way up here, and you have to put a huge volume just to get some way up here. So the caudal approach has become disfavored by most spinal injectionists. And this is another picture of transfemoral approach. You can see that the needle is going into the hole, right? And this is the method that I typically favor. This is the neck, and this is the interlaminar approach because it's going through the midline. If it was transfemoral approach, I'd be going through the side, okay? So those are the differences. Now, the indications for epidural steroid injections. We follow a common MTUS, medical treatment utilization schedule, and the ACOM and ODG. Um, this is what it says on the medical treatment utilization schedule, and that's a pretty good discussion, and it's not bad. So, epidural steroid injections are recommended as an option for treatment for radicular pain, defined as pain in dermatomal distribution with corroborative findings of radiculopathy. So, first thing we have to have is a diagnosis of or findings of radicular pain. So, what is the difference between radicular pain versus radiculopathy? Radic means the root, so nerve roots are found in the spine. It was Mixter and Barr, the two researchers that published the landmark study in 1932, describing this herniation as the cause of pain down the leg, what used to be called sciatica. They thought for the longest time that it's the sciatic nerve. We know that it's not. It has nothing to do with sciatic nerve anymore. Since Mixter Barr's study, we know that it has to do with nerve root that's found inside the canal. When the nerve roots are irritated for a variety of different reasons, including herniation and stenosis, uh, they can cause pain down the leg. So this is nerve root type of pain. So radicular pain simply means leg pain that's coming from the nerve root of the spinal canal, inside the spinal canal, or generally speaking, any leg pain that comes from the spine. The radiculopathy is a clear diagnosis. So radicular pain is more a descriptive term. Sometimes they will say radiculitis to denote irritation of the nerve root. But radiculopathy, pathy means pathology, right? So it's a pathology of the nerve root. So you've got a nerve root that's either impinged, crowded from stenosis, or impinged and irritated from herniated disc. And so that would be a diagnosis of radiculopathy. So it's similar, but there's a difference. This is a definitive diagnosis. Radicular pain is typically a description. So radicular pain is defined as pain in dermatomal distribution. What does dermatomal distribution mean? Dermatome uh, means a section of the skin that the nerve innervates. So there are multiple different nerves that go down the leg, right? So you've got L1 nerve that goes, L1 and L2 nerves that go into the groin, L3 nerve that goes through the medial thigh, L4 nerve that goes to the typically anterior thigh and into the knee. See that how it goes right across the knee. L5 nerve that goes to the side of the thigh and side of the calf like this. And S1 nerve is pretty much buttock and posterior thigh and posterior calf and outside of the foot. So this is what we call a dermatomal distribution of pain. Now, there's a lot of variation. Okay, I just did a block on a patient yesterday. Had this sharp stinging pain right into the knee, and it turned out to be the L5 nerve that's causing that. Typically, patients will have pain on the lateral thigh and lateral part of the knee for L5, and anterior thigh and into the knee pain for L4. But just remember the dermatomal distribution. Back of the thigh is S1, outside of the thigh is typically L5, anterior thigh is typically L4, and medial thigh you start getting to the L3, and then any groin pain is L1, 2, and sometimes L3 as well. So that's why we describe the location of pain on all of these patients. And we have similar dermatomal distribution in the cervical spine. I'll address that in a little bit. Okay. Um, but we really have to understand this closely. So when we ask for epidural steroid injection, the indication is what? Is radicular pain. So first thing you got to do is describe the pain down the leg. And what I like is also describing how significant the leg pain is, so versus the back pain. So the epidural steroid injections do not work for lower back pain, although a lot of the doctors, typically some uh, liberal spine surgeons will ask for a lot of epidural steroid injections. It's great for business, but it doesn't help the situation that much. And so when they have a lot of back pain and I get a request on an epidural, I'll just do an interlaminar shotgun approach and be done with it. If they have mostly back pain, 70-80% of the pain is in the back, and they have some diffuse pain down both legs, and the MRI doesn't really correlate very well, then I'll do an interlaminar shotgun approach. But for the most part, I go for a specific location. So if the pain is all mostly in the right side, then I'll pick the area uh, that correlates with the location of pain. And that's the where it gets a little bit confusing, but you guys will have to struggle through with that. Um, and let's just read this section just to get a general idea of what the MTOS guidelines say. Specific criteria below. Most current guidelines recommend no more than 2 ESI injections. Now, there was a time when we used to do 3 injections at a time. Series, I was never part of that culture, but I was part of training where we routinely did 2 injections. But nowadays, they only allow 1 at a time, which is fine. Um, it talks about series of 3, that there's no recommendations for that anymore. Um, Current recommendations suggest a second epidural injection if partial success is produced with the first injection, and a third ESI is rarely recommended. This does not mean that we can't keep injecting them. I'm okay with injecting 3-4 times a year. It's very difficult to get that authorized, but once or twice a year on these patients is completely reasonable. Um, Look at this statement. There's little information on improved function. I would disagree with this. If you find the right patient population, then you'll see that they improve function. It's a small population, but um, these injections can be quite helpful. The American Academy of Neurology, now neurologists are typically very conservative. They don't do these injections, so I don't know what the heck they're doing commenting on these epidural steroid injections, but maybe it's their opinion is more independent. But they concluded that epidural steroid injections may lead to an improvement in radicular lumbosacral pain between 2 and 6 weeks following the injection, but they do not affect impairment of function or the need for surgery, and then do not provide long-term pain relief beyond 3 months. Oh my goodness. Are you serious? So they can make you have improved pain, but it really doesn't make a whole lot of difference in the long run. Well, so this is a little bit of the controversial part, but I guarantee you, if you're a neurologist and if you had a herniated disc and you had a lot of leg pain, you're going to want that nerve injected to calm it down. And there's also a good argument for injecting the herniated disc and stenosis. And sometimes if you don't decrease the inflammation right away, you can actually end up with permanent scar tissue of the nerve root. So I like to inject these nerves as soon as they find out they have a herniated disc and a lot of leg pain. And here's a statement. Also, there is insufficient evidence to make any recommendation for the use of epidural steroid injections to treat radicular cervical pain. So there's less evidence for cervical pain. But if they have radiating arm pain and there's either stenosis or herniated disc in the cervical spine, we go for those. If they have severe, significant spinal stenosis in cervical spine, we have to be a little more careful, but you can ask for those. Okay, next, go to the next slide. Radicular pain, again, defined as pain in dermatomal distribution. Okay, so look for dermatomal distribution. In the cervical spine, you have dermatomal distribution. Look at the green part, that's C6. Um, when you, the easiest way to remember is to do a OK sign. Look at C6. Okay, that's the territory that you see when you have an OK sign. So this is this area right here, and then a part of this finger. Well, actually, this finger is not part of it. So actually, what you see in the circle of the OK. But there's much more variation in the cervical spine in terms of dermatomal distribution. So um, they're less corresponsive or corresponding. And so it would be nice to have herniated disc at C5, 6. You got C6 nerve coming out. So all the pain is in C6 nerve distribution, nowhere else. I rarely see that. And so if they have significant pain that's going down the arm, and then you see this herniation or protrusions in the cervical spine, we're going to ask for epidural injection, okay? And typically transforaminal uh, on the side of the symptom. But if they have pain in both arms, we can ask for interlaminar, like a shotgun approach. There's quite a bit of evidence that these transforaminal epidural injections are quite dangerous. I think it's because most physicians that do them have poor technique, but it is a risky injection. Fortunately, I've never had any problems in my career over the last 15 years. But now I think they updated the ODG guidelines and they don't recommend doing upper level transforaminal epidural injections. Um, and so interlaminar is not too bad, although a lot of physicians are quite scared of it. Think about it. In the lumbar spine, when you do an interlaminar approach, you can keep if you can keep pushing the needle all the way through the thecal sac, through the spinal fluid, and the other side to the disc in the lumbar spine, and all you've done was what we call dural puncture. You've punctured the dura, but you haven't caused any damage. You wouldn't be able to stab those nerves or the noodles that are going down. They'll just move out of the way. But if you do the same thing with a cervical interlaminar approach, what happens? Well, you're going to go right through the spinal cord, and you will cause spinal cord damage, which will be a huge lawsuit. And uh, there's just probably maybe 1 millimeter of space. Cervical spine is quite tight, um, and this epidural space is scary to hit, and it requires quite a bit of practice. It took me a little while before my hands. I don't typically shake, but I stopped getting scared of doing these things because this is kind of scary. But it can be done with practice. Yes. And so, radicular pain. When do you ask for epidural injection? You've got to have pain down the leg. That's the first criteria. And requires some positive examination. Now, sensory uh, examination is notoriously unreliable. We've done everything, the researchers have done everything, tried to objectify the sensory findings, including use of a variety of different instruments, but they have not been able to make sensory examination predictable, consistent, and objective. So um, we can kind of document that uh, based on patients' subjective complaints, but this is not a very objective finding. Now, the motor weakness can be quite objective. The best way to document motor deficit is by EMG. But guess what? Unfortunately, when you have a herniated disc, the motor system is the last system to go, and that would make sense, right? So we want it to hurt a lot before you actually get weak. And that's what we find that most people do not have motor deficits, although they have radiculopathy. And this is the part that most physicians, especially the non-specialist physicians, get mixed up. And I'm referring to the utilization review doctors. They think that you got to have positive sensory, positive motor to really have a diagnosis of radiculopathy, but that is not true. All you require is pain down the leg, okay, one of the positive exam and straight leg raise test is what? You lay the patient down like this, you keep the leg straight, and you start raising the leg until they say they have pain down the leg, and you record at what degree. Problem is that most patients that have had back pain, leg pain for a long time, they're going to have pain everywhere. If you do the straight leg raise correctly, then it's 90% plus specific for herniated disc and radiculopathy. But if you just document straight leg raise, that should satisfy the examination component because you don't have to have everything positive. But utilization reviewers use different standards according to their understanding, which is often incorrect. But make sure to document some examination finding either sensory or some weakness or positive straight leg raise when you're asking for epidural steroid injection. And then the third finding is that you must have some corroborating uh, radiographic exam findings and typically MRI. X-rays are not going to help. Uh, it was not part of my era, but um, CT scans with contrast, just a straight CT scan will not work. So myelogram or CT scan with contrast of the spine is called myelogram. Myelo means um, the spinal cord, and gram means the right? So they're trying to outline the nerves and the spinal cord. So it's called a myelogram. But the MRI is the standard, and you have to document disc herniation or stenosis, like a disc herniation right here. So L4-5, if they have a disc herniation at L4-5, you ask for lumbar epidural steroid injection. If the pain is down the right side, you ask for right L4-5 and 5-1. I've changed my mind about being specific. You can ask for 2 levels when there's a herniated disc. And I read an article that supported that. So since then, I've been asking for 2 levels. So criteria for use of epidural steroid injections: physical examination, uh, corroborated by the imaging studies and or electrodiagnostic studies. So if you have a EMG study that shows radiculopathy, then you don't even have to have an imaging study um, to corroborate it. But that's not very common. So you have to have dermatomal distribution. I'm sorry, you have to have leg pain, physical exam, and the MRI findings. And you have to document all those 3. Now, when do you do repeat blocks? When the patient has had 50% reduction of pain for 6 to 8 weeks, and they've had a reduction of medication use and some functional improvements. So just ask them if they're taking less medications. When they were doing great, did you require less medications? If they say yeah, and you can go into a little more detail. Um, were you taking less anti-inflammatories? Were you taking less sleep medication, less opiates? It could be anything. So just try to be specific. But say something about reduction of medication, and then ask them about function. Did it make you do more things? Did it make you walk more? Did it make you do more housework? Uh, did it help you get back to work or continue to work? Things of that sort. And then we can ask for repeat injections. So theoretically, we can do one every 2 or 3 months, but they'll never authorize that. Okay. So how to request an MRI? I'm sorry, how to request an epidural steroid injection? One approach is interlaminar, which is shotgun approach when pain is non-specific down both limbs, multi-level findings of protrusion, stenosis, or what have you. So this is shotgun approach. Transforaminal is more specific. So when you have a herniated disc at L4-5, for example, ask for L4-5 and 5-1. So just take both numbers and then turn it into the foramen, okay? And ask for on the symptomatic side. So if the herniated disc is L5-1, ask for L5-1 and S1 because below the L5 is um, they're fused, so they're just numbered by the holes. Okay, and for stenosis, go for symptom location. And this just takes, if you're still confused, just ask questions. But we do have to understand this well because this is something that we do a lot of. Okay, good. That's it for this slide.